Talofa Talilava, Malo Ilalei, Kia Orana, Borovanaka, Tēnā koutou katoa, warm Pacific greetings to you all, and welcome to Harakiki House. I'm Warren Owen, Chief Exec of Work Counts, and we're hosting this event this afternoon, and there's more information about Work Counts on your chairs, and what we do is to support organisations to develop and deliver evidence-based employment support services. We're here to spend time with Eóin Killackey, Awhia mai Okalani, and great to have you back in New Zealand.
It's so lovely also to see you all here, so thank you very much to you all for coming. Thank you, Warren and Work Counts, for hosting us. I'm really excited about the next hour ahead, and I thank Eóin very much for coming. And I said to him, would he come, and I would give him a tour around New Zealand, and then P.S. could you just speak, as you've just flown in. So I really thank you for giving that time. I know you've been travelling all over the world. I was going to mention the netball, and now I don't know what to say. But I want to say it's a real opportunity here in New Zealand. We're at a real tipping point as we look at transforming our mental health and addiction system. It's really crucial that there's a functional recovery focus to whatever we do, and so we just thought it was really opportune to have you talk to us about new models of mental health care, and particularly the work that you're doing globally around that. I also just wanted to say before Eóin starts, it's a rare quality that someone is so rigorous and thorough, a scientific communicator, as Eóin is. He's so clear about the research, but also so passionate about how to make it change people's lives and put it into practice. So I always take masses of notes when Eóin speaks. I know I've had a little preview of the slides, that there's masses of information there that he's going to take you through. So there's some real gems. But the most important thing is how we breathe life into that and bring it into practice here in New Zealand. So welcome, and we're looking forward to it.
Well, thanks everybody, and thanks for the lovely welcomes. And time was when you as an Australian could come to New Zealand and talk about all kinds of sport, probably. But we live in a changing world, so what can we say? I'm going to talk today about a few different things. Hopefully I've put a summary at the start. This is more for me than for you. I'm going to start off by talking a little bit about why we need a youth mental health system, or at least why I think we do. And I'll talk a little bit about the functional recovery and some of the focus on vocational recovery. And then we'll get to the stuff about a global framework for youth mental health care, which is the thing that I've been working on with some colleagues this year. Sometimes I might have a tendency to talk softly, so if you can't hear me at the back, throw something. That would be good. So in most places where there is a mental health system, this is pretty much what it looks like. We have a child and adolescent mental health system that goes up to 18. And if you still need care, you go into this adult system that goes through till around about 64. But what we know about that is that it's often quite difficult to make that transition from the child system into the adult system for a whole range of reasons. And even if you do, quite often people find it to be quite a not friendly transition, a very aversive sort of thing. Then if you still need care, you get into this sort of geriatric mental health system. But we know that quite a lot of people with severe mental illness don't make it to that point because they die between 12 and 20 years earlier than the rest of the population. Some studies push that even as far as 30 years ahead of the rest of the population. So in terms of all of these transitions, we sort of have these arbitrary junctions where the bits don't line up, and it's very much like this sort of picture of the train that kind of continues, but you wouldn't want to be on that train when it gets to that junction. We also know that the mental health systems that we have don't really match the epidemiology of illness very much. In most parts of the world now, and particularly our parts, most people survive early childhood. We get to our 5th birthdays overwhelmingly now. The next main health challenge we have after that is our mental illness, and all of this physical illness doesn't really start to pick up until we get into our 50s and beyond. I mean, these are all averages, but the main health challenge of young people is mental illness, and yet we put this arbitrary dividing line between the systems right in the middle of that onset of illness. So that the system we've got doesn't match up with the epidemiology of the illness. We know too that the system doesn't correspond with brain development for largely the same reason. This basically is just showing that our brain development continues into our mid-20s. And again, highlighting this sort of strange division here. I was at a talk once where someone was sort of saying that the peak age for all criminal offending is 17, which kind of makes a lot of sense when you think particularly for young men, you've got all the energy to go and do stuff, but you haven't developed the sort of brakes in your brain to avoid doing the stuff that you shouldn't do. And we also know that this system doesn't align with social development. So, 100 years ago, you could leave school at 6, get yourself a pair of long pants and a brush, and go out and be gainfully employed as a chimney sweep. But we know now that people are living longer with their parents than they've ever lived before. Part of that is because they tend to be studying for longer than they've ever done before. That's sort of the point at which people are reaching independence is delayed from what it used to be. And probably this one is important too. I mean, there's a lot of stuff about economics in all of this, and it's not to reduce people to their economic stuff, but it's part of this that you can't really avoid. But we know that this system isn't going to help very much with the economics around this illness. So if you look at the non-communicable diseases in the world, the 5 big ones, so cancer, cardiovascular disease, chronic respiratory disease, diabetes, and mental health. Mental health actually is the biggest economic burden of those non-communicable diseases. And it actually doesn't matter whether you're in a high-income country or a low-income, a low and middle-income country. Both in 2010 and projected out to 2030. By 2030, this is going to be costing the world, on this model, $6 trillion a year, which is a huge amount of money. Again, a different way of modelling it, and it ends up, again, just showing that mental illness is the biggest economic drag. And part of the reason for that is the time of life that it has its onset. So if you think about that sort of late teenage and early 20 time of life, that's when people are finishing school, they're getting qualified, they're doing training, they're beginning to get work. If that doesn't happen, you have a long, long time not doing stuff in society, but you also have a long time potentially on welfare benefits. The other thing about the economics is if you look at the projected population across the world, there's nowhere in the world where the proportion of young people is going to go down very much. A little bit here in Europe, but everywhere else it's pretty stable. Huge numbers of young people in Asia and massive growth predicted in young people in Africa. And again, if you don't look after that proportion of the population who are going to become unwell, and particularly if you're a developing country, you miss the potential development that those people can bring to your country as well. So this is a huge issue, and we need this new system. For about the last 11 years, we've kind of moved away from a sort of a dichotomous, either you have a disorder or you don't have a disorder way of thinking, to this idea of a staging model. And while this side of the slide is pretty, you can pretty much ignore that for the moment. And if you think about an illness like cancer, we're very used to thinking of cancer in stages. So if you catch cancer at stage 1, it's much easier to treat with less invasive treatments than if you catch it at stage 4. But we have this system where, in terms of mental illness, we've had a focus very much on this sort of recurrence and persistence or chronic stages of illness. And what we need to do is to move our focus back to this part, to try to get in before people even become unwell, so a preventative kind of mindset, but also if they do become unwell, to be getting in at the very earliest moment we can and providing as broad an array of treatments as we can. So not just focusing on the symptoms, but focusing on the other sort of elements. And in particular, recovery. So a little bit of history first. I think if you look at the purposes of treatment over time, and you go back to the asylum era, the main purpose of asylums was containment. And if you go back to some of the sort of literature about asylums in the Middle Ages, it was literally that. There was very little differentiation between people who we would now characterise as being mentally unwell and people who they just didn't want in society, and people were just put away and kept away. And even though there was the development of the sort of all the humane approaches in asylums, it was still very much about containment. Obviously, medications came along, and the purpose of medication obviously is the reduction of symptoms. Therapy, which obviously predated medication, but probably had a bit of a renaissance in the last 30 years. Lots of things around therapy, reduction of distress, developing a family structure and function, but not really much that directly links people back to what we'd more broadly think of recovery. So one of the first things I did in research was be a therapist in a trial of CBT for people with psychosis. And our focus in that wasn't helping people back to work or school, it was just reducing their scores on positive symptom scales. And in the rest of my clinical practice, nobody has ever come into me and said, do you know the thing I really want to achieve is I want a 5-point reduction on my BPRS score. Nobody's ever said that. But people have come into me and they've said, I'd really like to be able to get a job, or I'd really like to be able to move out of home and live by myself. And case management, particularly brokerage case management, is about putting you in touch with the bits, but actually not about doing the stuff itself. So what's missing in all of that, I suppose, was this idea of positive recovery. If you acknowledge it, it's not theft in academia. So this is from Patricia Deegan's presentation at IPS Works. And she made the very valid point that the way that we've designed systems hasn't been about the person who needs the help in the system, it's been about the system and what works for that. So we have short admission periods, we don't necessarily get people any more than stable and release them, often discharged to no great follow-up. And that's been good for the system, but it hasn't been good for the people who've needed help from the system. And we need to have a system that actually serves the people who need its help, not serve the people who work in it. And I think if we start putting recovery in the centre of things, this is what happens when you have too much time on planes to learn about the transitions in PowerPoint. If we have this system that puts recovery at the centre of things, I think we will actually start to do well on that. But this idea of recovery is relatively new. So when Alan Belloc was talking about a generation ago, he was probably only talking about the 1980s or 90s. And that the idea that a concept of recovery at that time would have been considered something of an oxymoron in the literature. Like, why would you do that? You treat people. Some definitions which I think are useful when we're thinking about recovery, and we'll talk about how it's not a simple concept in a second. But these are two sets of quotes which I think are really good. So the first one, in case you can't read it, says, recovery from mental illness involves much more than recovery from the illness itself. People with mental illness may have to recover from the stigma they've incorporated into their very being, from the iatrogenic effects of treatment settings, from lack of recent opportunities for self-determination, from the negative side effects of unemployment and from crushed dreams. Recovery is often a complex, time-consuming process. Professionals do not hold the key to recovery, consumers do. The task of professionals is to facilitate recovery. The task of consumers is to recover. And then Patricia Deegan, again, 23 years ago. And the thing about Patricia Deegan is she's actually a consumer researcher. She's got her own lived experience of schizophrenia. And she said the goal of recovery is not to get mainstreamed. We don't want to be mainstreamed. We say let the mainstream become a wide stream that has room for all of us and leaves no one stranded on its fringes. And I think they're good quotes to keep in mind for when we think about these things. So recovery is a very contested space, all the way from the sort of hardcore biological thing through to people with their own lived experience who would reject that completely. I'm not going to get into the whole pros and cons of any of those things, but what I am going to say is that functional recovery is a subset of recovery. It is not recovery in itself. Getting people a job is important, but it's not the totality of recovery. There's other things in their life that need to happen. And then vocational functioning is a smaller subset of the overall functional recovery as well, and I think that that's an important thing to keep in mind too. So what is this functional recovery thing, and why do we need it? So here's some more sort of definitions. So the first thing is we would expect people at particular ages to be doing particular roles. In every society in the world has got an idea of what you should be doing, given your age and the culture. So for Western societies, very much it's about education and employment. But when we look at what happens for people, we know that this doesn't happen for people with mental illness in the way that it happens for everybody else. So to start off with, we know that around about 40% of people stop going to school or university. We know about 30% get put off joining into the sort of social things that go with that, so clubs or activities. If you look at the career stuff, this is from some of Graham Thornycroft's work, this fear of negative reactions, or what actually in those papers is anticipated discrimination. People fear they'll be discriminated against. Nearly 60% of people don't apply for jobs because they fear they'll be discriminated against in that process. And 32% don't apply for education, again, because they fear they'll be discriminated. As an aside, one of the things, you mentioned stigma before, but I've really been thinking we need to move away from the word stigma, because stigma is just a noun and it's amorphous and nobody owns it. I think what we should be talking about is discrimination, because discrimination is a verb and we know who does the discriminating, and it's not the person with the illness, it's other people. So I think it's an important, because you hear stigma a lot, and I think it's letting a lot of people off the hook for a lot of things. So the second thing, engagement in social interactions. So that's an important part of functional recovery too. This is from the SHIP study, the Survey of High Impact Psychosis in Australia, which was a nationally representative study of people living with psychosis. And you can see there that the huge numbers of people not involved in any kind of social events or relationships. So at the top, you've got 70% of people who did not attend any recreational program in the past year. But even down at the bottom, 13% of people with no friends at all, so very, very isolated. And I think, we're beginning to look a lot at the sort of toxic impact of loneliness in older people. But I wonder what the toxic impact of loneliness is earlier in your life as well, and the things that it both doesn't allow you to engage with, the experiences it doesn't give you, but the contribution it makes to the sort of preservation of your illness as well. And I think there's something we've got to be looking a bit more at with that. And then finally, this other definition of functional recovery, performance of daily living tasks without supervision, including care of self, accommodation and physical health. You won't be able to see most of these graphs, which is very bad PowerPoint etiquette, by the way. The big one where you can see those declining numbers there, that's life expectancy of people with mental illness, and in the blue bars are people with psychosis. And you can see over that 20-year period, that's declining, and I'm sure that it probably is still declining. That's something we know about, but we actually haven't done very much to address. This is, again, from the SHIP study. This is talking about the accommodation that people are living in compared to their preferred accommodation. And the sort of take home from that table is very few people with psychosis are living in the accommodation that they prefer to be living in. They're either living with parents when they'd like to be living independently, or they're living in less stable accommodation than they'd like to be living in. So it's important that we address the housing stuff. People are using substances way more than the general population, and the biggest one there is probably tobacco. So that in that survey, there was 73% of males with psychosis using tobacco, and I think that compares to a population average now in Australia of about 12%. So huge discrepancies. And when should we get onto this functional recovery business? Well, this is what I was taught back in the last millennium, so it's not really kind of current anymore. When I was becoming a psychologist, this is what I was taught. Work would be too stressful for people. It would exacerbate their illness. They'd have failure experiences, so you should steer them away from it. You should steer them away from school for the same reason. And what you should do is you should work on their symptoms, and when they were well, when they'd had that 5-point reduction in their BPRS scores, then you might help them back to it, but probably with an understanding that they shouldn't go back to the thing that they'd really hoped to do, because that would be too much, but maybe some other kind of lesser ambition would be good for them. And particularly, help people access disability benefits. Know now that that's actually probably the exact opposite of everything that we should be doing. And it's interesting because at the same time that I was being taught that, there was all the stuff about how people with back injuries shouldn't be kept lying down for ages. And this is very much the same kind of model. My friend Mario Alvarez-Jimenez did this really interesting paper. We had this data set which looked at people with psychosis and followed them up 7 years on average after they'd first received treatment. And what he found in that was that if people had not made a functional recovery at 14 months post the onset of their illness, but they had made a symptomatic recovery, then at 7 years they were less likely to have made a functional recovery. But if they had made a functional recovery at 14 months, but not a symptomatic recovery, so they still had symptoms even though they were back at school or working, then at 7 years they were much, much more likely to be functioning independently. And so that says to me it's really, really important that we don't leave this until people are better, that we don't keep pushing that horizon further away, but that we get onto this early in the course of illness. And it's not the point of recovery, it's part of recovery. This is not something we wait till people are better, but this is something that actually helps people get better. This is Australian data, disability support pension data. The green bit of the bar is the proportion of people on our disability support pension who've got mental ill health as their primary disability. And you can see between 2001 and 2013, when we had a change of government and they stopped producing this helpful report, it went from about 1/5 of people to 1/3 of people with mental illness as their primary disability on the disability support pension. So huge growth across that time. And if you look at people aged under 35 on that pension now, 50% of them have mental illness as their primary disability. And the problem with that is, and I don't know what this is like for New Zealand, but the problem in Australia for that is that the two key exits of our disability support pension are the old age pension, so you turn 67, that's the 62% bit. Then the 22%, the 21.6%, that's death. So between the old age pension and death, that accounts for 80-odd% of people who ever get onto a disability support pension. And I think that if there's a young person who's got ambitions about what they want to do in their life, this is a terrible future to give them. Now, there's a lot of things you could say about making it easier to get off the disability support pension, more supportive to get off of it, but this is the kind of way things look. We're not completely Robinson Crusoe on this, so this is from the various OECD reports. Percentage of disability benefit recipients with mental illness. So the blue bars were all in one report in 2014, and then the red bar is New Zealand, which was published last year. And I have to admit that this is only something I've put together in the last couple of days, and I need to go and check because it seems to me very high. But what it's saying is that about half of the people on what seems to me your disability support payment have mental illness as a primary thing, which is high. So this is an important thing. And then when we go and ask young people what they actually most want help with from a mental health service, it turns out their health is this one over here. What they want is employment, education, relationships, housing, and health. And that sort of seems a bit counterintuitive, particularly for some of the more severe illnesses, because you would think that you would want to have, the voices out of your head or stop thinking the things you're thinking. But actually, I don't think it's actually that counterintuitive when you think about it for a little while, because I think what it says is that young people want what young people want, irrespective of what else is going on in their life. And I actually think that's a very powerful, positive thing to be working with. If we're working with people while they've still got that motivation, it's much easier than coming along when they've had 20 years of experience telling them they can't do things. So what I'm going to say now is that segues nicely. I'm not convinced it does. This is a bit of a shoddy juxtaposition. But anyway, into the employment interventions. So basically there's 3 types of employment interventions that have been developed over time. So social firms, which were a sort of a European development. And the idea is a social firm you may be familiar with is a business which provides employment at whatever the going rate is to people who are ordinarily marginalised from the labour market. There's good things about social firms. Obviously, there's no issues around disclosure because people know why you're there. Good social firms should provide a hierarchy so that people can come in with low skills and learn on the job and have positions that provide them further challenges as they mature in their sort of work kind of experience. The downside of social firms is that they have to survive in the community like any other business, and that's not always easy. And I suppose in terms of mainstream employment, philosophically, social firms don't see themselves as a transition point to other employment. They see themselves as providing meaningful employment in and of themselves, and you don't necessarily expect for people to make that transition through. Transitional employment is a much more US kind of thing. It came out of the Clubhouse movement, and the idea basically is that you would do a period of work experience of say between 6 and 9 months and develop work skills, and then you would transition into the open labour market. And the studies that have been done on that show that about 20% of people do successfully make that transition, which is not super high. And then supported employment, which is the idea that the best place to learn about work is in a job, so you help people into a job as quickly as you can, and you support them to stay there. And the most defined form of supported employment, and the one that all the research has been done about, is this thing called individual placement and support, which has got these 8 key principles. So firstly, it's open to any person with a mental illness who wants to work. There's not a concept of work readiness. If somebody says they want to work, then we work with them to get them a job. It's integrated with the mental health treatment team, so you cut out the sort of geographic and other gaps that usually people have to navigate by themselves, and that's often a problem, that we leave people with the least resources to navigate their way around these complex systems. I mean, it's not unique to work that we do that in either, as you would well know, I'm sure. There's a focus on competitive employment, and I think there's a few different reasons for this. One is if you teach somebody how to get a competitive job, and remembering again the developmental phase of life when mental illness has its onset, often people don't learn the skills of actually getting a job. So if you teach people how to do that, that's something they can take with them through the rest of their life. But I also think that if you help people get into competitive employment, it basically is one of the most normalising things that can happen for people. That you, in the rest of mental health, I don't think we've got anything that is as powerfully normalising as going for a job and someone wanting to give you the job, because that says, irrespective of whatever's going on in your life, I'm going to value you for the skills and talents you can bring to this work, whatever the work is. You know, that's a very powerful intervention, I think. Give people benefits planning, because the reality is most people aren't going to go into jobs that are so lucrative they don't need to worry about how to make the transition from their benefit to the wage they're going to get. Get on with the job searching quickly. In Australia, it can take a couple of months before, when somebody goes to a disability employment service, the assessment so they can figure out the level of support that, well, I'm going to betray my prejudices here, the level of support that they need to give them, or the amount of money that they're going to bill the government for, that assessment can take quite a long time, and that period can be profoundly demotivating for someone. If they've worked up the motivation to go to the agency, 2 months down the track, that motivation is not necessarily going to be there anymore if there's been no kind of progress. And you know what? Fair enough. So get on with the job search quickly. Develop employer networks, because obviously if you want to get people into jobs, helpful to know people who've got jobs. Get people jobs that they actually want to do, and then give them support for as long as they need it. So these are the principles of IPS. It's been extensively studied. This is a slide from a person called Gary Bond, who collects, as his hobby, the results of randomized control trials on IPS. And it's good that somebody does, so that we can have slides like this, and he updates it every time there's a new one. But the important thing is, whatever it's been compared to, wherever it's been compared to, it's outperformed the standard employment support in that place. And these trials have happened in, a lot of them in North America, but a number of them in Europe, a number of them now in Asia, and a few in Australia. So does it work in young people? So one of the things we sometimes get in youth mental health is go, well, you know, we all know that the youth unemployment rate is higher anyway, so young people are just unemployed. So it's maybe not, it's just that they're young, it's not the mental illness. So I looked at that. So this is youth unemployment currently in Australia. This is youth unemployment currently in New Zealand. This is the Australian average across the entire time they've been collecting youth unemployment data, which is the last 40 years. This is the New Zealand average over the time that that data has been collected, which is 15 years. So this is just population. This is the national average for headspace in Australia. So our national youth mental health service, 30% of people going to that unemployed. And then these three are from one study that we did at Orygen, where I work. So these are people coming to our depression clinic, people coming to our borderline personality disorder clinic, and people coming to our psychosis clinic. These are young people aged 15 to 25. And then this is from the SHIP study, people with schizophrenia. Young people with mental illness are not unemployed because they're young. It's like grossly magnified because they actually have this mental health issue. So they need a response. This is just showing the development of unemployment in psychosis. So about half of people very early on, and then it goes up quite quickly from there. So in first episode psychosis, there's now been about 15 years of research. This is my friend Miles Rinaldi standing on a mountain in Norway, because that's just what he does sometimes. Or it could be a mountain in New Zealand, sometimes it's hard to tell. But Miles did the very first study, not a randomized study, but a study of introducing IPS into just a regular first episode service in London, and showed that you could actually achieve quite good results. Let's see here. At 12 months, nearly, I think was about half of the people were doing stuff. Very few people were left not engaged in some way. We started a couple of years later, and we've done 2 randomized trials. So this was the first one. It had 41 people in it. We've got 6 months of IPS, and you can see very clearly there was quite a difference between the groups in terms of the number of people who got jobs, no difference in terms of education. They worked more, they earned more, and they decreased their benefits usage. Be fair to say, not everybody was as honest with our benefits agency as perhaps we might have advised them to be. So there was probably a greater reduction than we measured. One of the things about research is once you've shown something works, it's a lot easier to get money to find out whether it works. So we did a bigger study, doing largely the same sort of thing, but it had a follow-up and many more people. There was 146 people in this study, and we found much the same sort of thing at the end of the intervention. Lost the effect a bit there, and it was coming back there. It didn't quite get there. The interesting thing about this study, though, is we did it in the same place that we'd done the first study, and in between those 2 studies, we'd continued to provide IPS for about 2 or 3 years. We'd also continued to upskill the clinicians around employment. And I also think the culture had changed. So at the very start, when we first introduced an IPS worker, a lot of the clinicians were like, well, why would you do that? These people can't work. And of course, the first study gave the lie to that. And so I think we'd changed the kind of culture and the optimism that people had. We'd also skilled people up, like I said. Because the interesting thing about this control group, which is the green lines, is that they did better than most of the interventions in most of the chronic schizophrenia trials. So I think there's something really important in that, because IPS is often a rare resource. And I think if we can start to sort of stage how we provide a rare resource, that's a really important thing for making sure the people who need it most get the most kind of service. These are just a few other trials which I'll just skip through, but the basic thing, this is from New York. This is from all over America, and this is from LA. Like I said, a lot of North American stuff in this. They all show that IPS is the most beneficial form of doing it. This is an interesting one because it separated out employment and education and showed a very strong effect for education. It's the only one that's done that. But it was done at UCLA, so they're kind of an educationally sort of place. And this is just to say that we're actually starting to expand the research of this now to start. This is a trial that we've just started in Melbourne looking at using IPS for young people with borderline personality disorder who also have similarly poor outcomes vocationally compared to people with psychosis. But what about education? So we know that education in general protects. If you have more education, you're more likely to earn more money and you're less likely to be unemployed. Although, as I like to point out in this slide, up to a point, then it starts to go backwards. So you can have too much of a good thing. Bad like Helen having got your PhD just recently. I should have shown you that first. Hope you're not renegotiating your contract anytime soon. We also know that in the context of the way that the world's changing, and not just about sport, a lot of the entry-level jobs that used to exist are being automated, and that they won't exist for people who might have otherwise found an employment destination in those things anymore. And you can, every time I go to the supermarket, I think about this because the number of times that I'm the checkout person compared to in the past is increasing. And eventually it will be, they'll figure out a way that you can push a whole trolley through without actually, needing to actually speak to anyone. So a lot of those entry-level jobs are disappearing, and education is going to be much more important in that kind of context than it probably is. Well, it's important now, but it's going to get more important. The other thing that's obviously coming along with that is this whole sort of, I don't know if you know this sort of website, freelancer.com, and there's other sort of similar stuff where you can basically, I guess the old word would be you could tap for work. And the skills you're going to need to market yourself on that, I require a reasonable level of education because you're going to have to convince people that you're the person who can do the job compared to everybody else that you're kind of competing against. So education is going to be increasingly important. So we thought, well, what will we do about this? And we adapted the principles of IPS to education. Mainstream education, community education or a training course, again, open to anybody who'd like to return to school or training or feel that they'd like extra support to remain in what they're doing. Get them into appropriate courses as quickly as possible. It's integrated. Get people courses that are relevant to them. And so one of the things that...
I'm not sure I understand.
Thanks, Siri. I don't either sometimes. One of the things that we started to do is take a much more career focus on this, that, if instead of getting people into just like, a very low grade course that probably wouldn't provide them an employment connection, we'd work with them to develop up their skills so they'd get into something that actually would benefit their career down the track. And started to think, even though these might be young people we're working with, what do they want to be doing in 5 or 10 or 20 years' time, and what's the foundation we can start to provide to help them get to that place? And then, similarly, the educational consultant makes relationships with the local education providers. So we did this really tiny little study. We only had a little bit of money from our state education department, which meant we couldn't work with anyone older than 20, because that's just their funding rules. 6 months of intervention. At baseline, there was 11 people enrolled in something but not attending, and then 8 people who weren't enrolled, so they were not learning or earning. At the outcome, 18 of the 19 people had a successful outcome. They'd either completed the course that they were reconnected with, or they'd completed the prerequisites for the next part of their course if they hadn't completed the course. So in some ways, this seems like it might be even more powerful than just employment-focused IPS. Part of the reason for that, I think, is most educational places actually have units within them to support people. So unlike most workplaces, which won't, have a disability liaison officer to work with somebody, educational places do. So they actually actively there's a pull factor as well as the push factor. There's only one other study that we know of that's done something like this, which is another Australian study. It's very little again. There was 20 participants, 70% positive outcomes. There's something in this, and it needs a bigger trial to actually understand what that is. But if we believe that education's really, really important, it may actually need, for some people, and particularly for younger people, our headspaces go down to 12, that focus is probably necessary. Talk very quickly about translation and implementation for a bit, because I think it's important. We took what we'd done and we tried very hard for a long time to get the government interested in it. And we thought that they should just be, because it was great results and it had been in the British Journal of Psychiatry, and so why wouldn't you just change your entire policy based on that? It didn't happen. But what we did do in the end is we actually took the much more economic argument line. At the time, Scott Morrison was the social services minister, so we went to him rather than the health minister, because the health minister doesn't care. It doesn't come out of their funding the welfare benefits, but it does come out of our social services minister's budget. And so we said to him, here's this thing, it could potentially save money. And so he said what he'd do is he'd fund a trial of it across 14 headspace sites. And he put $17 million into it. And we got all the people together late last year. They've been going for about a year. Because of course it's a government thing, and so they've got KPMG doing the evaluation and nobody's allowed to know the data. So we just, because we know all the people, we said, how are you going? And they, at that point, had placed around about 800 young people back into work. And if you think about the disability support pension thing, in Australia, the average length of time somebody's on a disability support pension is 20 years, because most people on average come into it a little bit later in life. It costs over that 20 years a shade under $500,000. And so for that $17 million to be cost neutral, all we had to do was divert 34 people from getting onto the disability support pension. They'd already placed 800. So you'd think out of that 800, we probably had diverted that 34 people. And we went back to the one who was the minister, the social services minister before the election, and we said two things to him. We said, you only needed 34 people to pay for this, and it's probably easily done. And also, the guy who's now your boss set it up and he really likes it, so perhaps you'd like to score your own political win, which has got nothing to do with the research, everything to do with his career. But he put another $17 million into it to extend the trial both in time and to another 10 headspaces. So it's now at 24 headspaces. There's 110 headspaces in Australia, and there's a new social services minister. So we'll keep pushing, because I think this is from the American Journal of Psychiatry in 1918, and it's a report about the first 5 years of the first psychiatric outpatient clinic in the States. And in that report, it's got this paragraph that says some patients are referred for more investigation to aid diagnosis, others for employment, a special worker being maintained who has charge of the latter. Essentially, 100 years ago, they were already doing this, and somewhere along the line, that didn't get cemented into the system. And if you think about the millions of people who haven't had the opportunity to work over those 100 years since then, it says to me something very powerful about making sure this actually just gets cemented in as part of the culture of what we do, and not something that we just think isn't possible for people, or that we just shove off somewhere else, out of sight, out of mind of the rest of the care package that we're giving people. It's also really interesting that they also had a physical health worker. They were mainly concerned with syphilis, but they were much more attentive to the physical health of their patients too. So, how do we create systems of care that have recovery at their heart? And this is the second slightly awkward segue, which brings us to this global youth mental health framework project that we've been doing this year. And basically what this is a collaboration between Orygen, where I work, and the World Economic Forum, which you probably know from their Davos conference that Bill Gates and Bono go to. it does a whole range of other things too. But oh, and of course, Jacinda Ardern was a bit of a star at it this year. She was on the mental health panel, along with Prince William and 2 CEOs, and a psychiatrist. So, so this is how this project came about, and it came about because we have a youth research council. So this is a group of young people who advise us about what they think about our research. They also sit on our ethics committee, and they actually have the capacity to bar research from progressing if they don't think it's taken account of young people's views enough. But anyway, this guy, Carlo, was a member of that, but he was also a member of this thing that the World Economic Forum has called the Global Shapers, which are people under 30. And he said, would there be an interest of me arranging an introduction between Orygen and the forum? We're like, yeah. So then there was all this conversation, and what we came out of it was this joint project where we're going to, over this year, develop this framework for a global youth mental health care framework, with the idea that this could be applied into any kind of resource setting, so high-income countries and low-income countries and everything in between, and some places that aren't even countries at all. Partnership, 4 key deliverables. We need this global model, this global framework. We need an investment framework, so there needs to be, it's the World Economic Forum, so there needs to be some economics associated with it. An economic briefing for governments, and then a toolkit to support local advocacy as well, so that hopefully what we make out of this is resources to work on government, but also resources for communities that can advocate upwards about wanting to have their own youth mental health system. It's the team, doesn't really matter too much. Won't really know who those people are anyway. They're very good people though. There's a big youth engagement strategy. So we've got, there's a project steering group which has got 6 people on it, 2 of whom are young people. One's an ex-Orygen person and one's a global shaper. We've a youth partnerships facilitator who's also a young person herself, but she's actually employed in the project, working with the Global Shapers network, and we'll also engage young people. So we've done a lot of consultations in different countries with young people about what their issues are and what they think would actually make a good system. So this is the proposed framework. It basically consists of principles, and these are the currently 8 principles. So this is something we're going to finalise by the end of the year. So when I say currently 8 principles, it's literally true, it may change. But the 8 principles are rapid, easy and affordable access, youth-specific care, which is where the functional recovery fits in, because that's a key element of that, community awareness and engagement and stakeholder engagement, actually added to that, and integration, so that we're actually making things come together. Early identification, so means to actually reach out into the community and find people as early as possible in the course of illness. Youth partnership, obviously quite central. Family engagement and support. Continuous improvement, and that's not just sort of that kind of file auditing and making sure we're doing everything. It's a very broad kind of concept of that. And then this sort of health promotion, prevention kind of idea. So these are the 8 principles. And under each of these principles are a number of what we're calling practices. And there's heaps of them across the 8. So I'm just going to use, the rapid, easy and affordable access as an example. So the practices in that, so there'd be no requirement for a referral. So this would be a system that people can walk up to. There would be no gatekeeper for it, which is important both as a structural boundary, but also often if people need to pay a gatekeeper, whether it's a GP or something, that's also a boundary in itself. There'd be good relationships with child mental health services, because that's obviously something that you need an inflow from. Get the service close to, making it easy. So we've said close to public transport, but make it easy for people to get to. Ensuring it's open when young people can access it. So I was doing this talk about functional recovery a little while ago, and somebody said, yeah, but if people get jobs, they won't be able to come to their appointments with us. And I said, I was trying to be really restrained. And what I wanted to say is, guess what, we're a service industry. Be available when the customers are available, just like hospitality, you know? if people are getting work or they're at school, that's actually awesome. We should be celebrating that and having our services open when they can come to them, which might mean we need to think very differently about how our services operate. Make sure there's no direct cost to the young person as much as possible, and providing simple, free and a direct means of contact. So whether that's a phone number or something. I was talking to someone from Oslo. So this one service in Oslo, big service, had 43 different phone numbers that you could contact the service on. And I think that's incredible when in Australia, wherever you are in the country, you can call one number to get Domino's pizza and it will connect you to the local pizza shop and the pizza will be at your house 25 minutes later. We should be able to do that in our systems. And possibly quicker than 25 minutes, maybe. And then there'll be local implementation. So the way that that would work is you've got these principles with their various practices. The thing that we've become really kind of aware of as we've done a lot of consultations is obviously across different income places, different cultural places, and different resource kind of settings, there's a lot of local contextual factors that need to feed into this. So they're kind of equally important as the principles, and those two things need to come together to make this sort of locally operationalised youth mental health model that's consistent with the principles, that takes into account the contextual factors, but that's as ambitious and as innovative as possible. So one of the reasons why we sort of put that in there is that we don't want high income countries to go, well, we're doing enough already. We should always be kind of pushing the boundaries as much as we can in terms of what we can provide, but also thinking about innovative ways to provide it. And a really good example of that, in Zimbabwe, they've got 13 million people and 9 psychiatrists and I think 10 psychologists. That's their mental health workforce for that many people. So they developed this thing called the Friendship Bench, and the Friendship Bench is staffed by grandmothers, basically, because they're a culturally appropriate group to tell your problems to. But the grandmothers are trained in problem-solving therapy and pretty simple CBT. They're provided supervision, and there's actually a structured, it's either 6 or 10 session intervention that they've done studies on. It's within their context and their resources, it's really easy to put a bench somewhere that's a low stigma thing. It's low stigma to go and talk to a grandmother about your problems. It's highly culturally appropriate. It works within the resources that they've done, and it actually makes a real difference, like in a measured way. Like I said, they've done studies about this. So then all of this has to integrate with whatever the youth-facing agencies, whether that's education, whatever it might be, and also the existing primary and specialist care health systems if they're there. So, to conclude all of that, let's see. So youth is a very distinct developmental period, and hopefully I've kind of outlined the reasons why I think that this period of life requires a system that caters not just to the illness elements that come forward, but the developmental things that don't happen because of those illness things. One of those key developments is around vocational functioning, so in the broader sense. We know that people with mental illness are disproportionately vocationally disadvantaged. There's good evidence, I think, about that we know what to do. It's just making sure that we actually have a system that provides that to people, where they can access it, where it's useful for them. I think we should be increasingly looking at the way that we integrate the development of models of care with functional recovery, so that these are not separate things anymore. And one of the things I have thought about, partially because in some places in the world, schools are kind of the existing infrastructure. Places have schools. We don't necessarily have the resources to go and build mental health clinics and stuff, so why wouldn't we start to thinking about expanding what we understand a school to provide? So there's still the educational functioning, but if the buildings are there, why wouldn't we add on mental health services broadly defined that have all the functional recovery stuff in them, and then this kind of nice link between where young people are and what they need. No access barriers. It's important that we get this whole sort of spectrum of young people as well, so that we need to think about systems that integrate enough that we don't have that sort of missing middle problem. And it needs to be a young person-centred, culturally appropriate and co-designed system that's optimistic about the future for young people. Because I think one of the things that was kind of missing from many of my experiences in the Australian mental health system anyway was just any sense of optimism about the future of people. So thank you.
Thank you so much, Eóin, for that. It was just so fascinating. And people, if anyone follows me on Twitter, if I'm really not interested, I tweet a lot when someone's talking. And if I'm so interested and engaged in what someone's saying, I cannot tweet and listen at the same time. And I didn't tweet at all during the whole last hour. So I've written down lots and was trying to take photos so that I can. So it was just, there was so much. And I think for me, the big take home, there's lots, but was about how we need to build the system for young people and what people want, and build that into the culture. So vocational aspirations, functional recovery into our new system that we've got the opportunity to. Now, Eóin said he'll take questions, so please do take the opportunity to ask questions while we've got some time here. We've got about 15 to 20 minutes, a nice opportunity. Okay, please. Oh, Peter.
Peter Carson from Synergia. I was interested to remind me to, in Australia, doing a piece of work at the moment about childhood mental health, and all of a sudden, thank God, it's become a priority across the nation. And your principles are similar to, say, the initiative across in the UK at the moment around I Thrive and a kind of community development whole system. And the pushback we're getting in Australia is always about models of funding and models of contracting. And I wonder to what extent you've given thought to that around these different political and economic jurisdictions to ensure that the money does go to a community so the community can indeed lead it. You don't have bureaucrats designing a PAR system has to be the same again across the country. And how critical is that to success of these sorts of frameworks?
Well, I guess one of the things that we've sort of thought that, we started this in January, and it has to be delivered next January. So I guess our priority this year has been on developing that in the economic case, and we've got people working on that. One of the things is that we're hoping as we continue this partnership with the forum, because they've got accessibility definitely we don't have that kind of accessibility. The capacity to, connect us with the right people in government. And what I would hope is that we would begin to, after we've developed this, start to work with some interested people around the world to look at how you might implement it, and being cognizant of those sort of issues. So it's us educating about that, but it's also us learning about the system that they're working in, the constraints that they have. One of the other big arguments out of this will be the economic argument, and not surprisingly with the forum stuff. Because getting back to that point I think I made at the start, if you have a huge youth population and you let the potential of a quarter of that population go, that's just a huge developmental self-harm that you're kind of doing as a country there. So I don't know if that quite answers the question, but it's kind of the hope we have. Maybe it's hope and naivety more than practicality at the moment. But
I think it's a classic issue about how you get government agencies to kind of coalesce around a kind of a common agenda, or somewhat of their KPIs that are unique to their government agency, and kind of pull resources and give the responsibility and the contracting and the structural arrangements that need to support those agencies to work in an integrated way. Because everyone talks about integration, but no one's actually putting a cross-agency integrating mechanism in place, because they've all got their own responsibilities and KPIs. So
it's really tricky. Somebody asked, I was at this thing last night with, I've gotten tired now, Alistair Campbell, Tony Blair's thing, and somebody asked him a kind of a question, which I thought was a great question, because it was the question I wanted to ask. So it's a bit narcissistic, isn't it? But it was, you talk about health budgets or this, but mental health goes it's a sideways thing. And his advice really was that you need to connect with the people in government who aren't bound by that, which is basically treasurers and prime ministers, and get them to be the agenda bearers of it. Because if it's, the health minister's got a deliverable in the health budget, the social services minister the same, and but it covers everything. So we need those kind of people who do have the overview of government to be the people that we work with. And I guess they can delegate to different people if that's their kind of job. But and again, going back to the forum, I think, you know, they definitely have the access that, you know, if I rang up and said, I'm from Orygen, I'd like to speak to Boris Johnson, I mean, he might say yes, he's probably got a few things on. But, you know, let's say there was another more sensible leader of England in a few months, then they're the people who could get us to that person. So.
But we have that problem here. You know, we do have you know, the same as in Australia as in New Zealand around contracting, and I think you know, the wellbeing framework does provide us an opportunity to join that up at a cross-government level. So, any other?
It's Tanya Wilson. I'm from ProCare Fresh Minds, which is primary mental health. When you're talking about youth, you're talking about 224, because we know that the poor health is the 18 to 24-year-olds, and we also know that they're, certainly in the primary health, are less likely to be enrolled. So we've got quite sort of significant non-enrollment for that age group. So I'm hoping this framework is actually to that.
Yeah, so
it's one of our interest areas.
We're probably seeing it. Well, it's definitely 12 to 25.
Yeah.
And you know, what I think we're leaning towards is some fuzzy boundaries at either end as well. Whereas, you know, if you're a 10-year-old but it's more developmentally appropriate you be in that service.
Exactly.
And similarly at the other end, if you're 26 or 27, but it's still more appropriate that you're attached to that.
Any other questions? Comments?
I just like to make a comment, sort of leading on from what you were saying, but you know, here in New Zealand we have, I estimate, around 80 employment consultants integrated with adult mental health teams. That's slowly been growing, you know, in the absence of any mental health and employment strategy, because we've never had one. So there is no guidance on policy, from a policy perspective or from a funding perspective. The classic thing we see around the world, where whose business is it falls between welfare and health. So, and we have the opportunities to, you know, thinking about access and choice and social determinants as part of a wider view of well-being. So that's all of that. But, you know, I remember the last time you were here speaking, and I think that was 9 or 10 years ago.
Might have been, yeah.
And we did a bit of a roadshow around main centres, talking about youth mental health services. And in New Zealand at that time, in youth specialty services, mental health services, we had, I don't know, half a dozen employment consultants. John was a manager of mental health services in Wellington there, you know, was very brave, probably broke all the rules in the book, got some employment consultants to be integrated with within a clinical community mental health team. 10 years ago, half a dozen people. You know, we have less now in youth mental health specialty services. I feel so embarrassed.
I would say maybe a little bit more than 6 across the country. Well, I don't know what there is in Auckland in the first episode teams here, but in Wellington there's one in the first episode team there, but we also have, in Wellington there are also some in the CAM services, working with the older age group in the CAM services, where about at least a third of the outcomes are education outcomes.
So we've just gone backwards in 10 years. We have almost no, when we're talking about employment education, functional recovery support in our youth mental services. We may have won the netball, but we sure as hell aren't winning in this space.
And look at that graph that showed, you know, our disability payments so much higher than other countries.
Just to follow on from that, Warren's my name. I'm a barrister and researcher. I'm looking at models to extend the ACC type system out. Just to counter what Warren has said though, in New Zealand we have a small country, we have one government, we don't have the problem of what's the state's problem, what's the federal government's problem. We are a place where we can actually bring these things to life. So don't make it another 10 years, come back, we need a way to build this, and we actually have the opportunity here now to do it, which is probably the first time in a generation or two.
Yeah.
So we actually can start to go down this path.
Yeah.
And we just need some leadership and some planning, and we need to build a workforce to deliver the workforce and things like that. But we actually have the chance here.
Yeah, well, I think that workforce issue is really important, and to think about ways of both providing people the right training, identifying people with the right attitude, because a lot of this is attitudinal. It's like the belief that good things can happen, and then providing the incentives so that people, one of the things in the Australian employment workforce is this high churn because there's no progression. There needs to be a way for people to actually feel that they're continuously being challenged in their career, so they can continue to grow in it.
And also, if we look at how we configure employment assistance here, it's quite helpful to think about individual placement and support. And as an employment specialist, you would probably not see any more than 20 people, 25 at the most. So you've got 20 people to think about and be very intensively supporting. And if we look to our public employment system through work and income, now I know there's a couple of people from Ministry of Social Development here, but the most intensive employment assistance that our work and income case managers will provide is probably down to 60 at the least. So it's a very different type of, you've got 60 people to think about. Yeah. I know I could only, how intensive can the support be? And that's why people report that it feels like they're a number and not a name, and that's not a criticism of work and income, it's just what it's set up to do. But I think people don't realise that it's a low intensity. Even at its highest intensity, work and income is providing low intensity employment assistance.
Yeah.
Not,
it's the same.
Yeah. Any other comments?